So my task today is to talk about cubitus varus deformity, and some of this talk will be affected by actually the degree of the deformity that you're presented with. Other speakers have talked about timing as well. So the first is that we always have to start with acute injury. So in any of the things that have been presented so far, obviously the goal is to treat properly acutely. As mentioned, get your alignment, get your fixation, get your healing. So we all know most of these are extension type injuries. Associated neurovascular injuries are pretty common. We know about the classification, and that guards our acute treatment without any question. And obviously our goal is to get healing. The etiology here is failure to recognize the malunion or get an incomplete surgical reduction or a loss of reduction. So in many respects, this falls on us in terms of once the patient presents to us, proper treatment, and then go on to healing. And most of these children, fortunately, don't have devascularizing poor biology. What's the consequence? So it's been touched on a little bit. The first is the aesthetics. The second is that abnormal posture with a secondary fall increases the risk of lateral condylar fracture and Montesia fracture dislocations. You will see some kids who have a snapping tricep syndrome, and you have to sort out, is it triceps issue that's going on, and there's rare cases of true posterior lateral instability of the elbow. And occasionally, as mentioned, you will similarly get a tardial ulnar nerve palsy problem. And what's our treatment? So the first is natural history alone, and so lots of these kids have very good range of motion. The aesthetic problem is not significant. They don't have subsequent problems, and so we leave it alone. Or we begin to delve into corrective osteotomies, and there are many techniques that we're talking about, but if we're trying to get maximum correction in 3 dimensions, your dome osteotomy provides you with the largest tool. Most of these are step cut situations and generally tend to be closing wedge in which you can get slight 3-dimensional correction, as I'll talk about, and then you have to sort out your fixation issues, whether it's pins, plates and screws, or external fixators, and I think that's less significant. But again, if you have control of the osteotomy, good periosteum around you, you don't need as rigid a fixation, and these kids are young, so that generally will get their motion back if you operate on them relatively soon after their fracture in malunion. So this is a situation of never reduced, late presentation, cubitus varus deformity, and the question is whether you operate on this or leave it alone. We talked about loss of reduction situations, so that usually means that our pin fixation is not adequate. We don't have sufficient bicortical fixation, or we pull our pins too early. This is not a growth problem. Remember, 80% of the growth is in the proximal humerus, distal humerus, so if you use a growth-related technique, such as trying to slow down growth on one side and have increased growth on the other, that will not be an effective treatment around the distal humerus. And then there's a question of how bad is the aesthetics and how observant is the family. So although there's not a video here, we talk about that the grandparents are taking a video in a dance recital and they see this and it's quite disturbing to them, and they present saying, you got to make this better. So how do we make this better is really comes down to corrective osteotomies, and some of it is a technique of your choice. And so I'm just going to walk through a few of them, but dome osteotomy has been well written about, and what I would say to you is this gives you the best ability to have a complete correction for a very severe deformity without a subsequent step-off that you can see here in terms of translational problems. So you take and basically do a reverse dome, similar to what you would do in a mad lungs deformity, and rotate this back into position and fix it. So you get 3-dimensional correction with a dome osteotomy. Wedge osteotomies are most commonly what's used because fortunately most of the kids have compensatory motion through their shoulder and they have compensatory motion through their forearm, and so we sometimes advocate the KISS principle of keep it simple, and you can add in the last S for yourself. But if you maintain that periosteum on the medial side and protect your ulnar nerve, you can generally use that periosteum as a tension band and get your correction. So you can take out that wedge, and then you can end up, if you do an oblique cut, with a smooth surface on the lateral side. So here's preoperative drawing. You have Bauman's angle and the desired correction, trying to leave that hinge on the medial side. So we do this supine on an arm table. We usually use a tourniquet. We look at the carrying angles and Bauman's angle, and we have a defined goal. And our most important goal is not to lose control of the osteotomy at any time, because it takes a relatively simple operation and makes it harder. And the complication rate for this is up to 25% in the reported literature, and I think almost always it's because you lose control of the osteotomy. So here's our desired correction. This child's got 27 degrees of varus. We know the carrying angle compared to the other side. Here's our preoperative radiographic planning, so we're trying to get a 25-degree correction. The cut is planned above the olecranon fossa obliquely to correct that Bauman's angle. And you can get some correction of your flexion, but not extreme correction like you could in a dome. So if you walk through it, here it is. Place your pins, and they should almost just kiss on the medial side from lateral. And so you smooth wires in place, oblique wires lessen your step-off subsequently. You keep that initial wire just above the olecranon fossa. The second wire should touch just beyond the medial cortex, but not enough to penetrate the ulnar nerve on that side, but that's where it will be, so you're going to avoid the ulnar nerve issue. You then put your vertical wires in place before you do anything else, and these need to be much more vertical, so when you take the wedge out like a supracondylar fracture, they get good purchase fixation on the medial side. All right, fixation wires in place. The saw cuts are just inside the wires, so you can see here in a controlled fashion. Here is the visual of this vertical wires, corrective wires in place. You're going to come on this lateral approach, subperiosteal dissection anterior and posteriorly to perfect your neurovascular bundles. Locate the fossa, which is critical. Protect the radial nerve above in terms of your exposure. And then maintain that medial periosteal sleeve. It's your friend. Place your wires in place and make your saw cuts. And then remove the bone. We talk about it being really an 8 to 9 step operation. The last middle part of your bone you take out with a rongeur, so you see most of the bone is out. We're still stable. The vertical wires are in place. We nibble at that last little piece there, and now it's just a supracondylar fracture. If you have assistance, it can help because one person's reducing this, and the other person is just driving the wires home at the very end of the operation. Medial cortex is intact. You gently close the wedge. You flex and pronate like you would a supracondylar fracture, and then you drive your wires, which will now be a bit more horizontal because of the closing wedge. And then you add additional wires if you need to. It looks like a supracondylar pinning, so you're still in a flexed elbow. You put your pins across. If you need to, you add some more wires. Don't over-penetrate on the opposite side, and you can see it just closes down nicely, and now it looks like a distal humerus metaphysis again. And then you add additional fixation if you want to try and move this person early, so it depends on the age that you have. And you can see you get some flexion correction here if at the same time you're closing it, you do that flexion and pronation, and you end up with pretty adequate alignment without having to do a more complex step cut osteotomy or otherwise. So again, remove the majority of the bone, but not all of it. It's still stable. Don't lose control of your osteotomy. This is really the critical stage of this operation. And then you get your correction and your realignment just as desired. You put on a protective cast. We usually univalve the rebril so they don't get swelling. We put on something that we call big, fat, and ugly because the pins are taking care of this, and the pins usually come out at 4 weeks. We might add an additional 2 weeks until the osteotomy site is solid. And published results on this are really quite good and has been published out of our institution and others. So here's what we're after, is trying to take care of this and move it in this way. To just walk you through it one more time, and there it is. And there's the patient at the end, actually quite good. Flexion extension arc, quite good. So again, we're after happy patients when we're all done with this. If your deformity is more severe, then you have to go to a more significant step cut or a more significant dome osteotomy technique. And some of the lead presentation cases I've seen here out of India really do require dome osteotomy. So thank you. It's a great opportunity to be here and to present to you. Happy to answer questions, and I tried to finish a little early, so if we have to, we can also go backwards.
Morning. Great presentation, Peter. So, you mentioned you could do the dome or the closing wedge. Do you have a threshold, or is it just like a gestalt or a clinical judgment?
I really think it depends on the degree of three-dimensional deformity. So if you have what in America is most of the cubitus varices that are severe enough for surgery, so you're not doing natural history, a closing wedge is actually a great technique. If you have a very late presenting male union, three-dimensional deformity, you're not going to get it all in one cut. And so a dome helps. The other thing, which I didn't mention in the interest of time, but some of those really severe deformities will have the median nerve and the brachial artery stuck on the anterior humeral, and then they dive into that deficit, and so you also got to be very careful about that. So I think it really depends on the severity. So you got a 25-degree correction up to a 30-degree correction, that's fine on a wedge technique. You get more than that, it's really often badly spun. I think you have to go to a dome.
Okay. And just to follow up, so let's say you're in a situation where you've done the closing wedge, but you're not happy and there's a lateral bump. Have you sort of then tried to just translate it medially and leaving it as a closing wedge? I mean, that should work, right?
So you can translate medially as long as you don't put the ulnar nerve at too much tension. Yeah. You can nibble away a little bit of that metaphyseal bone and put it up the gutter if you so desire. And the same thing you can do if there's flexion. If you got a good anterior exposure and you still have a little bit of a bump up in front, you can nibble that away and put it in the lateral gutter. Okay? Yes, sir.
Thank you, Dr. Waters. If you have the two limbs equal, then probably you can prevent the lateral bump. My question to you is that if you have this deformity in an older adolescent, like for example 12, 13-year-old, do you feel the need for using any screw instead of K-wires in such a situation?
So great question. If you're older, I think you have to use plate and screw fixation, or some people use external fixation, but then it becomes an issue of stable enough fixation to allow you to move. Because the worst thing that you end up with is a straight, stiff elbow when you're all done. So you need enough fixation so you can move. In the younger, you can hold them in a cast for a while and still they'll get back their motion.
Good morning, sir. I want to know what is the amount of deformity which we can correct without getting any ulnar palsy or such symptoms.
I'm sorry, could you just say that one more time?
The amount of deformity which is corrected, and there are no incidences of ulnar palsy in that. What is the limit of correction by lateral closed wedge osteotomy?
So I think the closing wedge is up to about 25 to 30 degrees you can correct. I think obviously anybody under 15 degrees you don't have to do surgery on because they're going to be fine. But in there, and then the more deformity that you have, the more you have to worry about your medial ulnar nerve and your anterior median nerve, and even the degree of correction gets high enough up that you got to worry about your radial nerve. But we always do a closing wedge, which takes some tension off the neurovascular bundle. So I don't know if that answers your question.
And sir, are there
Can
any
we go to the
recurrences?
Yeah. Do you consider ligament laxity, especially post-operative PLRI, something? Are you dealing with it when you check on the per operative? If there is PLRI, something, how you deal with it?
So I think if I understand correctly, you're saying if you have posterior lateral instability, what do you do about it, right? So the first is that's a difficult diagnosis to make, and so we usually ultimately make that with an exam under anesthesia. And if that's truly the case, we first correct the deformity. And for some of the patients, when you examine them after you correct the deformity, that has provided stability. And if it hasn't, since you're coming in on the lateral side, we will actually do a ligament tightening procedure at the same time. And that usually...